I'll be talking about supply and demand in the world of renal transplantation. I'll get right into it with our problem statement. The demand for kidney transplantation is on the rise. The supply, however, has not been able to keep up with this demand. The number of transplants being done over the last decades have remained fairly constant in number. People with end-stage renal disease are waiting long times to get these transplants, and with these long times comes high mortality and morbidity. When we look at demand and look at the rates of end-stage renal disease, we find that in 2006, approximately 5,000 people were diagnosed with end-stage renal disease. This is an increase of about 34% in the last decade. The largest number of incident end-stage renal disease patients are younger than 75 years of age, and hence the majority of these patients will be eligible for transplant assessment. When we look at the times on dialysis before first transplant, there's a fundamental difference between wait times for cadaveric transplant versus LRD transplants. Deceased donor wait times reflect the time for assessment as well as the time the patient waits to get a transplant. It is a reflection of the limited supply of cadaveric kidneys as well as the time for assessment. In contrast, the LRD transplants are purely a reflection of assessment of the donor and the recipient. So when we look at and compare the national average with the BC average, we find that in the case of cadaveric transplant, the average wait time is about 1,200 days or 3.2 years, whereas BC wait times are coming close to 5 years. We're doing better with respect to LRD transplants, where the BC average is about 220 days compared to the national average of about 300 days. So why do these wait times really matter? Well, the mortality rate of patient on dialysis have been reported as high as 20% per year. In 2006 alone, there were about 70 deaths in patients waiting for a renal transplantation. The wait lists in some regions in the US are approaching close to 7 years. Wait times are exceeding the average life expectancy of most middle-aged people on dialysis with end-stage renal disease. While waiting on dialysis for a transplant, patients often develop new comorbidities, leading them to become ineligible for transplant, which leads them to be on dialysis, leading to further mortality. So let's have a look at our supply. There are 23 active transplant programs in 7 provinces in Canada. Over the last decade, there have been about 10,000 transplants in Canada, 60% of which have been cadaveric. The number of cadaveric transplants done over the last decades have remained fairly constant. The number of living-related donations, however, have doubled over the last decade. When we compare the gross number of cadaveric transplants done by each province, Ontario ranks number 1 with 243 transplants done in 2006, followed closely by Quebec. However, Ontario has about 6 adult transplant programs. So if you look at just 2006, the mean number of transplants done per program in Ontario were about 40. In comparison, BC did about 30. When we look at living donors, Ontario does the most once again, followed closely by BC. However, when we break it down per program, BC does more, at about 48 per program. So how does BC really compare? Well, last year we did about 167 transplants, 80 of which were living donors and 87 were deceased donors. Average wait time for cadaveric transplants in BC is about 60 months compared to the national average of about 40 months. At present, about 230 patients are waiting for a cadaveric transplant. Looking at just the LRD transplants in 2007 at VGH, the median turnaround time for living-related recipients from referral to transplant was about 351 days. That's coming close to a year. 87 days from referral to clinic and about 215 days from clinic to the actual surgery. So why are these wait times so long for cadaveric transplants? Well, the most important reason is that, as I've already mentioned, the incidence for ESRD is on the rise, while there's no proportional increase in the number of transplants being done. There has been a decline in donors with brain death. There's a lack of education amongst general public with regards to importance of organ donation. Surveys indicate that about 85% of people support organ donation. However, only 15% are registered with BC's organ donor registry. There are outdated misconceptions regarding body mutilation and inability to have open casket funerals that often deter patients to donate organs. While most religious groups and sects consider donation to be a charitable act and encourage it, there are certain religions and cultural groups that are against it. So, coming to living-related donations, as I've already mentioned, there are fundamental differences as to why the wait times for this is longer. And this pretty much comes from long processing time. And the long processing time for living-related donations stems from many reasons, namely skill shortages. There are shortages amongst transplant nephrologists for donor and recipient assessment. There are shortages in our surgeons, in OR time, social workers, psychologists, nurses, and coordinators. There are long wait lists for assessment for special tests, referrals. Patients have to wait for cardiac evaluation, access to specialist consultation. There are no dedicated resources for transplant assessment, transplant patients. There's often a lag time between the time that the recipient is referred and the donor is referred. There's often a lack of OR resources. However, this is becoming less of an issue, at least in VGH. There's lack of common protocol and clinical pathway for evaluation of patients entering the assessment process. Whether there's rigorous exclusion criteria with variable thresholds, trying to keep the donor as safe as possible. So there have been several strategies used to overcome the long wait lists in BC for deceased donor wait list. These include mainly encouraging living-related donation by earlier patient education to inform recipients of treatment options and to facilitate more donor pairs. Expanded criteria donors. St. Paul's recently began non-heart-beating donor program. Education amongst healthcare practitioners regarding speedy referrals for appropriate donors, and utility-based allocations. Strategies which are already in place to improve waitlists in BC with respect to LRD transplants include live anonymous donation, paired exchange donation, and preemptive transplantation. Other strategies which have been proposed are centralized streamlined processing and assessment of donors and recipient with possible consolidation of the two transplant adult programs which exist. Of course, getting more resources with nephrologists, surgeons, psychologists, and social workers. We already exposed the donors to a risky operation. Can this risk be further stretched? Whether the answer lies in making the eligibility criteria for living-related donors more lenient is still in question. So we have admittedly a daunting task at hand. We currently have a decentralized, fragmented system with 3 sites, 2 hospitals, 2 health authorities, with all their respective multiple levels of red tape. Any change to this process demands money, whether it be a review or implementation. What we need is a method of studying transplant operations from global to granular level, modeling it, changing multiple simultaneous components,